أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. I am Professor Syed Ali Haider. Previously I was explaining the clinical chest radiology where I have done 2 sessions. This is the 3rd session. I have already told you about this. These sessions actually, clinical radiology sessions are 8 in number. So try to repeat it as much as you can to understand radiology, because without radiology you will not be able to assess correctly the patient. It is one of the routine investigation. You have to read it yourself. So in the previous one I have briefly described that this is the session which is before starting the session I have already told you about the requirements. Should be PA view, the patient should be standing, should be still, deeply inspired and hold the breath properly, and the patient should be in straight line here. Although there is scoliosis seen in the thorax, no problem, but the trachea should be central, it should not be rotated, and it should be deeply inspired and hold the breath properly. These are the basically for the PA view are concerned. And I've told you about the protocol. The first our requirement should be fulfilled. You should already fulfill the requirements. Secondly, go for the bony skeleton, try to describe it, and the trachea should be central. Should not be displaced to the right and the left, although 10 degrees towards the right is normal, and at the sternal angle, this is the sternal angle, at the 4th thoracic spine, at the level of the thoracic spine. Here, the right principal bronchus and the left principal bronchus arises, and the carina is there. The carina's angle is 120 degree. So it should be, the trachea should be central. If it is more than 10 degree on the right, it is abnormal. 0 degree towards the left is abnormal. It can be displaced to the same side. Same side means that some pressure is exerted on it. It collapses because the upper part of the lobe of the lung is collapsed. Or secondly, it can be displaced to the same side because of the contractures or cicatrization of the fibrosis here. It can be displaced to the other side, but the pressure forces like pleural effusion, very huge pleural effusion, or pneumothorax on the side, spontaneous pneumothorax. And the third one is the tumor which can displace it. There are conditions in which although the pathology is there, bilaterally present, and for example fibrosis, it will encircle all the trachea. The trachea neither be displaced, should not be pulled or pushed, I mean to say that. This is called splinting of the trachea, because the pathology is there. The trachea should be displaced, but it should not be displaced because of the forces are balanced here. When forces are balanced here, all the pathologies are present. This is called splinting of the trachea. Now we are coming to the very important part of our discussion, and that is lungs. Now lungs should be classified as the fields or areas or zones. The lobes may be upper and middle and lower. On the right side, on the left side there are 3. The bronchopulmonary segment on the right side is 10, and the left side is 9. So where the lobes are concerned, it is difficult because of the clinicians to describe the lobes, but it is better to describe in the lung fields, areas or zones. These are the lobes actually. On the right upper lobe and the right upper lobe on the lateral view, and the right middle lobe, and then it is seen in this. It is difficult because of the fissure, the minor fissure, the major fissure will describe it rather. At the same time, the right lobe on the right lobe on the lateral film. It's a difficult one. On the left side, there are two lobes, left lower lobe and the linguala, left upper lobe is linguala. Linguala is this. The linguala is this here. So it is difficult to describe the demarcation line for us is concerned. So it should be very, very deeply penetrate, if you will. Then you can understand. Otherwise, this is very difficult as a clinician is concerned. That this is easy one. That the lung fields can be described. Imaginally, the line should be drawn at the level of the line of the second costal cartilage. Imaginary line. Transfer line. The second line will be drawn as the fourth intercostal cartilage. Here it is drawn. In this respect, there are two lines, the upper lines and the lower lines. The right lung is divided into right upper zone or field, left, right, middle zone and left lower zone, or right lower zone, sorry. So right upper, right middle, right lower, left upper, left middle and left lower. There are 9 zones, 1, 2, 3, 4, and 2, and 2 or 2 and 2, 3, 6. The 3 on the side and this 3 on this side. Only the mediastinum inside, between it, the middle mediastinum. There are 6 zones or fields should be described. What you see in this field, the 2 things are normal. One is aerogram being the air in the alveolar spaces, and secondly, the other thing which is normally seen are the blood supply of the lung, which is called the bronchovascular markings or ray markings. So they are normal. So there are alveolar spaces we call aerograms here, and the blood supply of the lung we call bronchovascular markings or ray markings. The 2 things are normal. The third thing, which is an alien one, opacity for example, it is abnormal, always abnormal, until and unless proved otherwise. It should be remembered and it should be keenly observed. X-ray should be seen very, very clearly. You see, the apices should be compared, then the part of the upper lung should be second intercostal space with the second intercostal space, third intercostal space with the third intercostal space. In this fashion you go down behind until the costophrenic angle. If there is a mismatch between these 2 fields, this means there is something going wrong. There's a tennis match, you see the ball on one side, another ball. You move the neck on the one side and then move the another on the other side. Just like a tennis match, you are watching tennis match. Compare it for the aerograms and bronchovascular markings. Bronchovascular markings, aerograms. Bronchovascular markings, aerograms. Bronchovascular markings, aerograms. So the texture of the lung in this fashion is described. Very easy to remember if you follow my instructions. So these are the 6 lung fields, and every lung field should be seen separately, compared to the other side. The 2 which are normal in the lung field aerograms are normal. They are normal. What are they? That is, first is the air spaces, aerograms, and between the streaks are seen here. Lines coming from the hilar. They are more, more in the diameter at the center, and go toward the periphery. They becomes tapering from the central to the lateral side. In the middle, you will see very clearly these things. And the lower, very, very prominently bronchovascular markings are seen because they are active during the inspiration. More is the inspiration, more is the effort, more are the bronchovascular markings. This is the rule. After running, you will take this X-ray, all bronchovascular markings will be visible. Unless the middle zone have got the bronchovascular marking, yes, but less amount, less in quantity. In the lower zone, huge amount is seen. Huge bronchovascular markings. This is the breast shadow. Upper border should not be visible of the breast shadow. Now this is how we take a normal one. You will see these bronchovascular markings ends here. That is about 2.5 centimeter to the lateral wall. They ends, not they are crossing here. This is the outer, you can say, side, 2.5 centimeter outer side of the lung fields. This one. So these bronchovascular markings should not cross this line. If they are crossing this line, it means that at the resting phase, the lung field showing the vascular congestive changes. You have seen in the reporting the congestive changes are seen. What do you mean by congestive changes? Bracket may probably they are bronchitis. And this is not the answer. These are normal things are a normal one. Abnormal will be abnormal. This is a normal one that the aerogram and the bronchovascular marking are the normal components. The bronchovascular marking ends here, not crossing this. Neither they are present in the apices of the lungs, the supraclavicular fossa. No bronchovascular marking in normal sitting posture. Very slight bronchovascular markings are seen in these zones. Very, very, very thin. It's no problem. They are not crossing even. So this is how I interpreted it. All your efforts should be to see the bronchovascular marking aerograms. Compare it. The rule should be followed. The radiotexture of the lung field, every lung has the proportion of aerograms and the bronchovascular markings. They are proportionate to each other. On the basis of the observation, all pulmonary diseases, all, starting from the bronchial asthma in your book, and lastly it is the tumors arising from the lungs, or even lung transplantation is the last topic. On the basis of this, all pulmonary diseases can be classified into 5 groups. On this basis, number 1, aerograms and the bronchovascular. Aerograms are more proportionate, but they are proportionate to the bronchovascular marking, which are also increased in size, in number. For example, the smoker's lung. I detected the smokers with the lungs, fields, and an X-ray. He said, the patient said, I am not a smoker. Okay, you are working in the factory? No, not in the factory. I am not smoking. 18 years boy said, I am not smoking. 67 years of age. My neighbor said that please examine me and please advise me for the test. So I have given a slip for the routine examination. That is blood CBC, remnant blood sugar, urine DR, and X-ray chest. When the chest X-ray was examined by me, seen by me, I said that they are normal in the smokers. But he said, what you are saying? Manaka, you are a smoker, therefore these lungs are normal to you. They are a smoker lung. Can it mean that it will be increase this problem? Yes, Manaka, yes, of course. In 5 years you will become COPD patient. And this is my prediction. So he quit smoking at first day. And he died 2 years back, 3 years back because of some prostate problem, not for the lung disease. He quit smoking. So first of the condition, the aerograms and BVM are equally increased lung, smoker lung. Secondly, the aerograms are normal, but BVM are increased. For example, in acute bronchitis, it is seen. And in chronic bronchitis, more you will see the both aerograms are increased in this condition, as well as the bronchovascular markings are increased at one time. But here, acute bronchitis, the aerograms are normal, but there will be increase in the bronchovascular markings. Secondly, the third type of the problem is that more aerograms are there in proportionate to the bronchovascular markings. For example, COPD, generally speaking, because this is a big topic, aerograms are more visible than BVM. Fourth are the condition, only aerograms are aerograms, no bronchovascular marking at all. Only, it means pneumothorax or a bulla, emphasis is bulla, for example, locally speaking. Fifth condition, there will be aerograms, there are BVM, but plus alien is there, radiopacity, for example, pneumonia. These are fifth type of the disease. So all lung diseases are divided into 5 groups according to the radiological parameters. This is my way of thinking. It is not written in any book. After 48 years of teaching of these radiology or electrocardiography or routine examination, etc., I concluded that all diseases have got the problems. If you want to check them in this fashion. Now here the first one is the increased bronchovascular markings plus increased aerograms. Both are there. This is smoker's lung. Darkening is there. Bronchovascular markings are very thick. देखिए middle zone में देखें, lower zones में देखें. And normally in the lower zones there are bronchovascular markings. Okay. But normally on the right lung field, not on the left. But in this person, the bronchovascular markings seen on the left lower zone, whereas the middle zones are also, they have. In the normal lung, there is only aerograms are much visible on the right side, not on the left side. He has got the bronchovascular marking on the left side also. He is a smoker person. He denied, okay, but to me it is a smoker's lung. Now increased bronchovascular markings plus they are the normal aerograms. Increased bronchovascular normal aerograms. Here normal aerograms are there, but these are flushed out or masked by the increased bronchovascular markings. Aerogram, bronchovascular marking, aerogram, bronchovascular markings. These are lines you see, bronchovascular marking all over there. You see usually in acute bronchitis. After the upper respiratory infection, cough occurs, productive cough occurs. It is a part of the disease. No problem. Do not become, you do not become panic to see these type of X-rays. They are very common one. So it is the increased bronchovascular marking plus normal aerograms. Here increased aerograms, opposite. In all aerograms, very thin bronchovascular markings, very less amount of the bronchovascular markings are seen here. This is the condition you see in cases of the chronic obstructive pulmonary diseases, whether it is the polar end of emphysema or the polar end of the chronic bronchitis. In chronic bronchitis, much bronchovascular markings are penetrated into it. But this is the difference between the emphysema and the other part, which I said that is the chronic bronchitis. Only allograms and aerograms. Look, there are no allogram, only allograms on the left side, and there are no bronchovascular marking, zero. On this side there is air in the pleural space. It is pushing also. So there is pushing of the mediastinum to one side. So spontaneous pneumothorax, this is, and it's pushing this, what is called the middle mediastinum push to the other side. The classical left lung pneumothorax. Now only allograms, no bronchial marking, same thing. This is one, and it is the part of this lung is here. The lung marking also visible here. So this is a pneumothorax, although it is not spontaneous, severe type of a pneumothorax. The lung margins, remnant lung margins are seen, and there are air spaces in it. This is another example of it. Only allograms and allograms. This is the part of the lung which is left here, sticking on this side. pushing the mediastinum to the other side. It will cause a problem, and patient will die because of the cardiac arrest at one time. And this is the trachea. Look, the trachea is shifted here. So look the shifting on the trachea. Pushing effect of this large pneumothorax. Another example is small pneumothorax. Here you see this part on the left side. This part. Look this side. There is no aero bronchoscopic markings here in this side. बिल्कुल डार्क है ये और इसकी कट भी नज़र आ रही है आपको ये पार्ट की स्मॉल लीनियर कट although it is difficult to detect, it is less than 25%. It will heal up no problem. More than 25% is dangerous. But 20-25% about of the whole lung capacity, it will just cause breathlessness and nothing. You can manage the patient very well. Only anograms and anagram, no box crawling, is invisible as bulla, localized. Look at the margin of the bulla, there is no anograms inside. It is the hallmark of the severe bronchial asthma when the patient tries to overload or work or running instead, although the lung capacity was reduced and the impediments blabs will be, it will burst out and it will cause this bulla or it will cause pneumothorax. If this bursts, it will cause pneumothorax. There are no bronchovascular markings. It is seen here in this case. So this is the end of the session 3. Here you see the 4 types of problems about proportionate to the aerograms and the bronchovascular markings, and the 5th type of the disease where the aerograms is there and the bronchovascular marking is there, but there is a alien, opacity is visible. I will try to, inshallah ta'ala, go through on Thursday night interactive section of this. Until then, I hope so that you will revise it and inshallah you can understand it very well so that I can go through. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.